The following video is intended to assist providers in understanding recent changes to the Santa Clara County EMS stroke protocol. Providers should review the protocol in its entirety, as this video will only highlight changes that have been made. Currently, the Santa Clara County EMS system utilizes the BFAST stroke screening. On December 18th, the system will no longer use BFAST and begin using the GFAST stroke screening when assessing a patient for a stroke. The transition to GFAST will add a stroke severity scale, which in turn will assist providers in stroke center transport determinations. A flowchart has also been added to the protocol to provide better understanding of the decision-making process. Before getting into the details of the changes being made, it is important to know that there are several quality improvement committees that help direct the EMS system. The Stroke Care System Quality Improvement Committee is one of these, and is an important part of our EMS system. The committee is a multidisciplinary peer review committee composed of representatives from primary stroke centers and other designated professionals. The changes to the stroke protocol are a direct result of this committee's continuous efforts to improve the stroke care for patients in Santa Clara County. Since the 1990s, patients suffering from a stroke have been treated using thrombolysis, also known as thrombolytic therapy. This treatment can dissolve dangerous clots in blood vessels, improve blood flow, and prevent damage to tissue and organs. As medicine has advanced, physicians are now able to perform a procedure known as a thrombectomy. This is where the clot is able to be mechanically removed through a surgical procedure. It is important to note that this procedure is not able to be performed on all strokes. This is why first responders' assessment using the GFAST stroke screening is important. In Santa Clara County, 10 of the 11 emergency departments currently have the capability of providing initial brain imaging, stroke neurology consultation, and thrombolysis treatment if it is indicated. A hospital with this capability may request to be recognized as a primary stroke center. Of the 10 primary stroke centers, 4 have the capability of providing more extensive care for stroke patients, which includes thrombectomy and/or neurosurgery. These hospitals are recognized in our EMS system as comprehensive stroke centers. Now let's begin to review the changes to Policy 700A13. The first major change pertains to the stroke screening process. The objective in switching to the GFAST screening is the identification of acute stroke patients most likely to be candidates for thrombectomy. As with STEMI, early intervention with thrombectomy can significantly improve patient outcome. However, thrombectomy is limited to large vessel occlusion ischemic strokes. Changing to the GFAST screening will assess for gaze deviation or conjugate gaze and will help in the identification of patients who may benefit from this intervention. The removal of the balance assessment and eye assessment for diplopia has been replaced by an assessment for gaze deviation or conjugate gaze. The assessment for facial paresis, arm motor weakness or pronator drift, and speech abnormality such as dysarthria or aphasia will remain the same. The time of the symptom onset or time last known well is still also included in the assessment and remains a vital piece of information for providers to obtain. In a moment, we will provide instruction on how to assess for conjugate gaze, but first we need to understand the addition of the stroke severity scale. The stroke severity scale is a point system added to 4 parts of the GFAST assessment. Each of these items will be scored 0 if absent or 1 if present, for a maximum score of 4. The total number of points on the GFAST screening, in addition to the time the patient was last seen well, will be used in the stroke center transport determination. In other words, will this patient need to go to a primary stroke center or a comprehensive stroke center? The following will demonstrate how to assess for gaze deviation or conjugate gaze. It will also provide an example of what a normal response looks like. To assess for conjugate gaze, begin by placing your finger about 12 to 18 inches in front of the patient's face. Ask the patient to track your finger without moving their head as you move your finger side to side horizontally. This was an example of a normal response and would be scored 0. This is an example of gaze deviation. The patient is able to follow the target to one side horizontally, but unable to continue following the target to the other side. This would be scored 1. Here is another example of gaze deviation. You will notice the patient has a forced gaze deviation to one side, and no eye movement is seen. These are examples that gaze deviation is present and is scored 1. To assess for facial droop or facial paresis, ask the patient to smile or show their teeth. If both sides of the face move equally, score 0. If one side of the face does not move, score 1. Now let us look at how to assess arm drift, also known as pronator drift. Begin with the patient's hands resting in their lap. Ask the patient to raise their hands with the palm up. If one arm begins to drop, this would represent arm drift. This example showed a normal response and would be scored 0. Now let's look at an abnormal response. This is an example of an abnormal response and would be scored 1 due to the arm drift. Another example of an abnormal assessment is when the patient is unable to move one of the arms. This finding would also result in a score of 1. At this point of the assessment, you have been talking to the person for some time as you walk through the gaze deviation, facial droop, and arm drift assessments. You should have a good idea if there is dysarthria or aphasia present. If unsure, ask the person to repeat a simple phrase. If the person has family or a friend on scene, you may also ask them if the person's speech seems normal or if they are noticing a difference as well. If normal, score the assessment 0. If abnormal, score 1. The final piece of the GFAST screening is to establish when the patient was last seen well. If there is a reliable historian on scene that can state the patient's last time seen well, ensure that their contact information is collected and documented. Upon completing the GFAST assessment, you should now have a stroke severity score as well as a time the patient was last seen well. If the patient has 4 points on the GFAST stroke screening and a last seen well time of 6 hours or less, transport the patient to a comprehensive stroke center. If the patient has 3 or less points on the GFAST stroke screening and or a last seen well time greater than 6 hours, transport the patient to the closest stroke center, comprehensive or primary. By using the GFAST stroke screening, we can obtain the GFAST score. The score and the time the patient was last seen well will be the basis for the destination decision. A patient with a GFAST score of 4 and last seen well time is less than 6 hours, they will be transported to a comprehensive stroke center. This means an ambulance may bypass a closer hospital to get to a comprehensive stroke center. Patients who score a 3 or less on the GFAST screening, or who score a 4 but the last seen well time was greater than 6 hours, will be transported to the closest stroke center. Please remember to notify the receiving hospital of a stroke alert when transporting a patient that meets either of these criteria. Due to the changes in stroke screening, the documentation tab in ImageTrend has also been updated. To access this, click on the Stroke tab under the Complaints and Findings. Once the tab is open, click on the appropriate findings to document your stroke assessment. An option of Unable to Test has been added to each assessment. If this is the result for a specific item, please specify why within the narrative. In addition to the stroke screening, an area has been added to record the name and the contact number for the historian from the scene of the event. This would be the family or friend who can state the time the patient was last seen well. Once the patient arrives at the stroke center, the treating physician may need to contact this individual. This information can greatly impact the patient's options of treatment, which is why it is so important that responders document this information. As with all areas of medicine, modern EMS is a moving target. As we move forward and learn more, We should anticipate changes in the way we provide emergency medical care. If you are interested in participating and attending any of the quality improvement committees that help guide our EMS system, please reach out to your department's EMS program manager and let them know of your interest. If you have any questions about this video or feedback on the delivery method used, please feel free to contact the EMS agency through the email listed.